So what kind of protein is erythroferrone and how does it work? How does it ensure suppression of hepcidin?
So erythroferrone is a member of the C1q-TNF superfamily, which contains well-known proteins such as tumor necrosis factor, adiponectin, and now erythroferrone. And the evidence that's gathered in multiple labs points to erythroferrone regulating the transcription of hepcidin by interfering with bone morphogenetic protein signaling, and specifically interfering with ligands that are required for hepcidin production, BMP2, BMP6, and the BMP2/6 heterodimer, from getting to the receptor that drives hepcidin transcription, the BMP receptor. So the way erythroferrone appears to work is that it interferes with the access of bone morphogenetic proteins to the bone morphogenetic protein receptor.
So ERFI works as a trap for BMPs. How is ERFI in turn itself regulated, the production of erythroferrone in the bone marrow?
It appears that there are two major factors that regulate the production of erythroferrone. The first is stimulation by erythropoietin, the hormone that is made in the kidney in response to anemia. So erythropoietin stimulates the production of erythroferrone. But second, which might be just as important, is that the level of erythroferrone is higher when there are more cells that make erythroferrone. So the production of erythroferrone is proportional to erythropoietin stimulation and the number of cells that secrete erythroferrone, the volume of erythropoietic precursors, of red blood cell precursors in the marrow. So you see particularly high levels of erythroferrone in situations where erythropoietin is high and the number of erythroid precursors in the marrow is greatly expanded. An example of such a situation is the disease beta thalassemia or Cooley's anemia, in which, in the extreme cases, every bone in the body is packed with red blood cell precursors, including the scalp, the fingers, you name it. So there's a massive number of red blood cell precursors, erythropoietin is high, and the levels of erythroferrone are sky high in that situation.
Since we're talking about production of erythroferrone, which physiological conditions are associated with higher erythroferrone production?
We already mentioned that erythroferrone goes up after bleeding. And so that would be a situation in which anemia is causing oxygen levels in the kidney to drop. That causes the production of erythropoietin, which stimulates the production of erythroferrone. So bleeding is one situation. Hemolysis is another situation. Hemolysis is the excessive destruction of red blood cells, which causes anemia, again, decreasing oxygen tension in the kidney, stimulating the production of erythropoietin, and that then stimulates the production of erythroferrone. So any situation in which you have red blood cell precursors in the marrow and anemia at the same time, any situation like that will lead to increased production of erythroferrone. Where it will not occur is when there are no red blood cell precursors in the marrow. No matter how high erythropoietin is, if there are no red blood cell precursors in the marrow, as in aplastic anemia, you will not get high levels of erythroferrone.
So erythroferrone is important for physiological adaptation to bleeding to ensure that enough iron is provided for red blood cell production. How about pathological situations? Are there pathological situations where erythroferrone is overproduced, contribute to pathophysiology of disease?
Interestingly enough, there are a number of anemias in which, rather than having iron deficiency, which is the common form of anemia, you have iron overload. So there are anemias that actually cause iron overload. And this can happen in two settings. One is if the patient receives transfusions, which contain a large amount of iron. But interestingly enough, it happens even if there are no transfusions given. So patients who have this specific kind of anemia will develop iron overload even though they never get transfusions or rarely get transfusions. So they hyperabsorb iron. And it turns out that these are the patients who also overproduce erythroferrone. Why does this happen? This happens because of a phenomenon called ineffective erythropoiesis. Ineffective erythropoiesis means that red blood cell precursors develop up to a point and then they die. They don't give rise to red blood cells. So they are developing, they're secreting erythroferrone, and then they drop off, dead. So erythroferrone is being produced, but mature red blood cells are not being produced. So the iron is not being used. So on one hand, you're mobilizing iron, increasing iron absorption, and on the other hand, you don't make many red blood cells that actually end up using the iron. So the iron is essentially being accumulated in the body and not used for the production of red blood cells.
So in anemias with ineffective erythropoiesis, the bone marrow overproduces erythroferrone. Erythroferrone suppresses hepcidin and allows hyperabsorption of iron and development of iron overload. So erythroferrone is one of the key pathogenic mechanisms by which patients with these diseases develop iron overload.
That's exactly correct. And we have shown that by taking mice with ineffective erythropoiesis, specifically the disease beta thalassemia, and knocking out erythroferrone so that they can't make erythroferrone, and it substantially but not completely corrects the iron overload. So the iron overload in ineffective erythropoiesis, or specifically in beta thalassemia, is in large part but not completely dependent on the production of erythroferrone. And we don't know what the other factors are that contribute to this picture. There are some candidates, but we don't really know.
So now we're talking about pathological setting where erythroferrone is overproduced. And you mentioned beta thalassemia as an example of disease where erythroferrone is overproduced. Are there others where erythroferrone is overproduced?
So any anemia with ineffective erythropoiesis, so it's not just beta thalassemia, but other anemias with ineffective erythropoiesis include anemias such as certain sideroblastic anemias, congenital dyserythropoietic anemias, of which there are several types, pyruvate kinase deficiency, and perhaps others even rarer than these already rare anemias. And the key features that we look for is that red blood cell precursors multiply, but they don't give rise to mature red blood cells.
Erythroferrone was also shown to be overproduced in sickle cell anemia and myelodysplastic syndromes. So it may be a biomarker in those conditions as well.
Yep. So erythroferrone is probably more widely produced than we think, although those situations may not be as dramatic as ineffective erythropoiesis in the classical sense as in beta thalassemia. Some ineffective erythropoiesis may occur in sickle cell anemia, as you mentioned, and also in certain types of myelodysplastic syndrome.
So what are the potential clinical uses of erythroferrone measurements?
I strongly suspect that erythroferrone is an excellent index of ineffective erythropoiesis. So if we measure erythroferrone, what we are actually measuring is the amount of red blood cell precursors that is active. And that combined with the presence of anemia. So if you have anemia and you have ineffective erythropoiesis, that will be marked by high levels of erythroferrone production. Anemia drives erythropoietin, and the ineffective erythropoiesis then is what's generating the high levels of erythroferrone. So I would expect, and this remains to be shown in more detailed studies, I would expect that measuring erythroferrone is the same as measuring ineffective erythropoiesis.
And the higher erythroferrone, the more severe ineffective erythropoiesis, and the greater risk of developing iron overload in patients who have higher.
So erythroferrone then becomes a marker of predisposition to eventual iron overload, even if transfusions are not in the picture. So as more and more patients live with ineffective erythropoiesis, specifically in thalassemia intermedia, as they survive to longer and longer, they will develop iron overload, and we will need to anticipate that. And measuring erythroferrone will allow us to anticipate this.
Could we also use erythroferrone to judge the effectiveness of therapies for those disorders?
So to the extent that the therapy increases the effectiveness of erythropoiesis, it should make erythroferrone drop. So if a therapy actually allows more red cell precursors to live and give rise to red cells, erythroferrone should decrease. So it might be an excellent pharmaceutical marker for drugs that effectively promote erythropoiesis and make it more efficient.
It will be very important to measure erythroferrone given its physiological and pathological roles in iron metabolism. So how can we measure erythroferrone?
The best way to measure erythroferrone is to measure its levels in blood, specifically in blood plasma or serum. And we can do that through an immunoassay. Immunoassay typically involves a pair of antibodies that are used to detect a ligand. So we have such assays. They detect the physiologically relevant form of erythroferrone because the assays detect a rising level of erythroferrone after the expected stimuli. So after bleeding, they detect a rising level of erythroferrone. In anemias with ineffective erythropoiesis, they detect a high level of erythroferrone in proportion to the severity of the anemia. And finally, in hemolytic anemias, they also detect the appropriate rise of erythroferrone. So the current immunoassays for erythroferrone are detecting the physiologically relevant erythroferrone levels.
In addition to the pathological conditions we just discussed, where erythroferrone clearly has diagnostic utility, can you think of any additional conditions where erythroferrone measurement may be useful?
We have a number of tantalizing hints for erythroferrone acting in non-hematologic capacity.
So it sounds like some applications for ERFI are just starting to be discovered, and it sounds like the future is going to be very exciting for the applications for erythroferrone.
Yes, it is likely that we are just seeing the tip of the iceberg at this point. We have hints that erythroferrone is important in cardiac regeneration, that it is important determining the sizes of fat depots in the body, and it may have additional developmental and physiological roles. So there's a lot to look forward to.